Welcome to the AIM Spotlight Series. I'm Dr. Karina Testa. I'm the owner of AIM Sports Medicine and Physical Therapy in Hermosa Beach, and I'm the host of the AIM Spotlight Series. With us today is Dr. Tracey Didinger. She's an orthopedic surgeon, wife and mother, high rocks competitor, former lifeguard, and an all-around nice human. She's part of a practice called Advanced Orthopedic Care, and she specializes in shoulders and knees. She's been in private practice over 7 years after finishing her clinical residency and her fellowship, and she brings an innovative approach to her care. She's also a South Bay resident with her husband, a firefighter, and her two young children. And welcome, Dr. Didinger.
You for having me. That was such a nice introduction. Thank you.
You're welcome. So I always like to start with, how did you become an orthopedic surgeon? Where did that come from? How did that evolve?
So I'm kind of the typical orthopedic surgeon story that I was an athlete my whole life, grew up as a swimmer, and I had to have my first surgery when I was 13. I had shoulder surgery by 13.
Wow.
So I had my first introduction into orthopedics because I was a patient. And over the years of being an athlete, I probably spent more time in my orthopedic surgeon's office than I did my pediatrician's office. So when I thought of being a doctor, I always thought that meant being an orthopedic surgeon. So if someone asked me as a kid, like, what are you going to be when you grow up? I didn't respond with, I'm going to be a doctor. I responded with, I'm going to be an orthopedic surgeon. And so I would say I was hyper focused on that my whole life going into schooling. So I stayed an athlete all the way through that time. And in undergrad, I was pre-med, I was a bio major, sports med actually minor, and chemistry minor. And then I went straight from college right to med school. I didn't take what's probably more normal now, any gap years. I went
Yeah.
straight from North Carolina to Philly. I did my 4 years of med school there. And again, if anyone asked me from the day I entered med school what I was going to be, it was going to be an orthopedic surgeon. It didn't really sway at all, quite frankly, in those 4 years.
Wow.
And much to the dismay of probably a lot of people, that you should not always be that vocal, maybe. And then I did my residency at USC in ortho, and I always knew sports probably was what I was going to do. I liked other areas of ortho, but sports was really what I loved from both what the surgeries are, but also the patient population. I like that healthy aspect of a patient. I like knowing they have like a goal of function to get back to, and it's you're helping them with their daily life, but with something that maybe brings them joy or peace outside of just their daily stuff. So that was why
Hmm.
sports always intrigued me. And so then I did that sports medicine fellowship in Colorado for a year and then came back to private practice life here.
Wow. That you were definitely focused right from the start. That
Yeah.
is impressive. And what sport were you playing growing up?
So I started as a swimmer, and then
Yeah.
by high school, I got into water polo. So I was doing year-round both of those. And then in the background, I always did something called surf lifesaving, which is a sport that's pretty unknown in our area, despite we're a beach community. It's very big in other countries, but not so much in the US. But that has to do with sporting events around what ocean lifeguards do. And
Okay.
so I really got into that during my teenage years and ultimately kind of transitioned out of the pool all to ocean racing. And I was on the national team through college and med school, getting to travel internationally and compete in surf life-saving races. And then I even trailed that into my time at USC because I was still in the area, so I could still train.
Mhm.
And then when life caught up to me and having babies and being a wife, I put it kind of all on the back burner. And now I definitely don't race in the ocean. Now I race on land, which is the irony of it. But I was really an aquatic background person.
That's what it sounds like. Lots of aquatics.
A lot of
And
aquatics.
yeah, and that's interesting that you managed to balance that much competition and training all through college and all through med school. Did that keep you more organized or grounded or
I think most athletes will say that being an athlete teaches you time management, right?
yes.
Like, you have practice at this time, so you have this many hours to do your homework, you have this time dedicated to school. And so I think it very much gave structure, and that started as a child, right? But I think that idea of being an athlete and that time management skill helped me as I progressed through schooling, that I could do all these things. And I had to get creative. In North Carolina, there wasn't a beach in Chapel Hill, so
Yeah.
I had a paddle board that we kept in the shed at my house in North Carolina, and I would actually train on the river where the crew team practiced.
Oh, wow.
I would have my paddle board, and then I had another set of things in California, and I would like fly out to meet the team wherever they were, and then I'd go straight back to class. And even up through med school, I again, probably not wisely looked at. I missed my white coat ceremony, which in med school is
Oh,
kind of a big
no.
deal.
That is
It
huge.
was it was a choice I made because my national championship was held on the same day as my white coat
Uh,
ceremony. I had been training so much and kind of was at the peak of my athletic time in that sport. And so I went to orientation for med school and then I flew to Miami and I raced. Ended up winning the whole thing, which was great, but I never even had
wow.
a white coat ceremony. So like that was maybe slightly frowned upon, but big picture, I obviously took my Hippocratic oath. I'm a doctor. That I
Right.
just another like cool moment that like I got to finish on top, and then like literally that next day I was in my anatomy for my first day of med school.
Wow. Wow. What a story. So for those that don't really understand what the training is beyond medical school, can you kind of walk me through what residency looks like, what fellowship looks like, and what they actually mean?
So in medical school, all students are getting the same education, and you're getting a very broad coverage of a lot of things that are like medicine oriented. But in particular, orthopedics, you really don't get that exposure in medical school. I probably only rotated on an orthopedic surgery rotation for maybe 6 weeks at most in the time
Okay.
you actually have to pick the specialty. And so with ortho in particular, you really hone your skills after you leave medical school. So although I finished med school in 2013 and I was a doctor, I was an MD at that point, my skill set really developed in the next 5 years in residency. And not all residencies are the same length of time. It's
Mhm.
specialty specific. So orthopedics is a 5 year program across the country. Some are actually 6 years because they build in a research year. Mine did not have that track that I was at. And so you spend the first year of residency being exposed to many of these surgical specialties. So you rotate on neurosurgery, plastic surgery, vascular surgery, general surgery, and then you spend 6 months on ortho as well. But it's trying to get us kind of exposed to all the surgical areas, although we
Mhm.
won't be changing like what we're doing. And then
Right.
years 2 through 5 are exposing us to ortho in all the various fields because in orthopedics, you cover spine surgery, hand surgery, pediatrics, tumors, sports, joint replacement. So those next years are really spent like targeting all those areas and learning them. And then during your 4th year, you actually have to pick what specialty you're going into. So
Yeah.
you do that before you're even going. You actually have a whole nother year of residency. So 4th year residents then start applying to their fellowship. And it's very common to do. It's not very common not to do one. Some people do two of them.
Wow.
You go around and you apply to programs. You fly out in the middle of the night to go interview. You come back. That was pre-COVID. I think now a lot of them are remote, but when I did,
Yeah.
you actually had to go and interview at the program. And then you go through another ranking process and you match during 4 years. So I already knew a full year before we were moving to Colorado that we would move away for a year. So it's kind of a
Yeah.
weird thing that you're like, you see something in the future, but you're not even done with your training and then you go away. That fellowship year is usually all 1 year fellowships in the various areas of orthopedics. And that is really where you're honing in on your craft and what you're doing.
Okay.
And so in sports medicine, that was a lot of shoulder surgery, a lot of knee surgery, and then also sports team coverage is a big part of a sports medicine fellowship. So I was covering the University of Colorado sports teams, football, basketball. We did a lot of lacrosse coverage, and then we covered a professional team there, that the Colorado Avalanche.
Mhm.
So it's also the first time you're leading athletes in a little bit different way and working with the athletic trainers, working on hands on deck with the therapist and everybody so that you're targeting athletes with like the best approach. So you do a lot in those 6 years, but the irony is I don't use a lot of what I did in medical school now other than anatomy.
Yeah.
My
Yeah.
skill set really came to fruition in the training years.
So now I've got to ask, because I know things have changed over the years, but being a female in orthopedics, is it still a male dominated field, or
Very
has
much
that changed?
no, well, it is changing, and I'll say the reason I know this is We are very much the minority. I think we're less than 5% of the
Okay.
orthopedic field is females. However, match day just happened last month,
Uh-huh.
and a lot of the programs will post their incoming class and say
Mhm.
these are the group that we match. And it was mind blowing how many were female dominant classes. I mean, I saw
Wow.
multiple programs where over 50% were females. And
Wow.
it was not like that at all. My class was made up of 10 people, and I had me and one other female in my class.
Mm.
USC was very much female friendly, meaning there were more females at USC than I saw at some programs. I interviewed some places where they had never had a female resident before. And
Wow.
that was like a very odd experience. And as much as people were open-minded to things, the questioning that would come up in interviews was like mind blowing. I got asked one place why my husband wasn't at the interview with me because wouldn't he be making my rank list for me? And like
Oh my gosh.
it was like, and they say it with like a straight face, like no big deal, like
Yeah.
this is a
Yeah.
normal question. And I'm like, I'm like, no, like he'll go where I say we're gonna go. Like this is
Yeah.
like this is not like up to him to decide where I'm gonna train next. And it was still crazy to think that was only what I interviewed in 2012, 2013, and those questions were
Wow.
happening. Not only then the will you be having a child while you're here?
I
Like
was wondering about that one. Yeah.
that came up a lot. And in residency, married my husband during after my intern year, but I'd already been with my husband for 5 years before that. So we knew children was very much on our life plan.
Mhm.
And it was not common. It's not common for females to have babies in training because you don't really get that normal cookie cutter maternity leave experience.
Right. Right.
And I got asked on plenty of on questions like, "Hey, do you plan on having a child in the next 5 years?" And that's
Wow.
again mind blowing, right? That
Yeah.
can be asked of you, but it is. And I get why, meaning you leaving a program for any time affects all the other residents, right? Affects your
Hmm.
training, it affects your exposure. So it happened a lot. Then my next story was that during my fellowship, I was pregnant during my interviews and nobody knew. I was pregnant
Yeah.
with my son, my first son that I was going to have in residency. So the baby was going to be born before I even got to fellowship, but I was actively interviewing pregnant and hiding my pregnancy.
Yeah.
And then all of a sudden you match and I come back around and like you had a baby, like because it was that secretive, like you weren't really openly talking about the fact that you were having kids, even though it had nothing to do with the program. It was
Right.
still
Right.
something that you just did not talk about. And then I
Yeah.
was pregnant in my fellowship, so then I'm in the locker room with a big old belly pregnant being a doctor. So it's just like you make time
Hey.
for what works for you
Yeah.
and your family, but there were not like role models for me to really like base this off of. I didn't meet a female orthopedic surgeon until I was in residency.
Wow.
Yeah.
Wow.
There's just not
Yeah.
that many, but now it is becoming better, which is great. And there's a
Yes.
lot of
Yeah.
groups to support that. And I think there's a lot more that women can talk about it. And questions are asked. They're asked about maternity leave. They're asked about family planning, about fertility, like all these things, which I think is
Mhm.
great in our field because we are such a minority that I think it is going to be like, it's only evolving for the better, I think.
Yeah, that sounds like it. So switching gears a little bit, how did you in your fellowship, how did you decide that shoulders and knees were kind of the two areas that you really like to work with?
I think I just enjoyed the surgeries. I enjoyed the pathology. So I always joke in sports, I feel like I'm playing a video game in someone's body because I don't actually stare inside someone's body with it like wide open. I'm staring at a computer screen or a
Right.
TV screen and my hands are doing all the work. And it was just something that some people love arthroscopy, which is what I mainly do, and other people
Mhm.
just can't stand it because there's like a spatial orientation to it. It is weird. You're not staring where your hands are, but I liked it. I took to it. I probably related to a lot of my shoulder patients. I could tell them kind of my own experience, and I think
Mhm.
having the ability to relate to your patients is really good. And then the knee stuff, I love meniscus work. I love ACLs. So that's kind of where I was exposed to a lot, but it's probably tailored more towards those two body parts from an operative perspective over the last several years.
Got it. And has any of the surgical techniques started to involve robotics or started to involve that new
In
technology?
in the what I got trained in, so in particular like sports medicine and shoulder and knees, there's always been robotics happening with knee replacements. That's not a new
Mhm.
thing. Same thing with hip replacements. But in the last year or so, now robotics are entering into the shoulder replacement. I personally have not been in a robotic shoulder yet. I've seen colleagues showing videos and things because it is very much coming forward with that. Still, what I'm doing is not as robotically driven. That being said, we are getting more into patient specific instrumentation. So
Okay.
we do have a lot where we are using different platforms to create guides. For example, in shoulder replacements, we're recreating people's anatomy with 3D reconstruction to really try and like optimize our surgical technique and replicate what we're seeing from MRIs and X-rays and CT scans to then recreate that for the patient. So that part is very much evolved since I left fellowship and become more just standard to do that.
Mhm.
But when I was in fellowship, that was just like
Just
kind of me
starting.
just starting, and not even everyone who trained me was on board. Like they were still doing it not by eyeballing, but like
Yeah.
different techniques versus like the actual true computerized version of it.
Anything AI wise that's coming up in this area?
AI wise, I think we're seeing that more on the clinic side, right? Like that's helping all clinicians in medicine, I think, with documentation purpose
Correct.
and maybe trying to make us more efficient in that regard. My version of AI has been more trying to wear glasses to take more pictures for my patients as I operate to show them things.
Oh, that's
So
cool.
I'll wear like the Meta AI glasses that
Hmm.
allow me to like say start video and show patients in real time kind of what I was seeing as I was doing their surgery. In arthroscopy, we always had photos and video capabilities, so that's not a huge change. But in some of
Hmm.
more of the open procedures, it allows someone that has interest. And if patient says like, I don't want to see that, then we're not going there. But I think
Right.
it's a good learning tool that I can feed back to myself like, okay, I can do this different. I can change this technique, and it gives me a little bit more just knowledge or practice on my hands. The AI part, I think, is interesting that patients are coming in smarter, right? And you probably
Yeah,
see that as well. They're coming
for
in
sure.
with other types of questions that maybe we weren't getting asked before, or their opinion about their treatment, which I think is always important. You need to hear your patients and what they desire and what their goals are. But I do think it's made some of our jobs harder as
Hmm.
clinicians because you have to outsmart the computer
Yeah,
or
you have to compete with Dr. Google.
right, you have to compete with it.
Hmm.
And some patients don't want to have that open conversation because that was so like set a certain way online, and you have to really, and we should be able to show our stuff, right? We should
Of
be
course,
able to
yeah.
rationalize what we're doing, and if we can't, we have no business doing it, in my opinion, right? So that part has been a learning curve too, at how to
Hmm.
like outsmart Dr. Google or like to at least explain it. Reddit.
Yeah.
I've had to defend meniscus surgery against Reddit threads. And I've never
Oh,
even been on Reddit. And I was like, oh, that's on there? I thought it was like for pop culture. I didn't know
I
like
thought so too.
I
Yeah.
did not know meniscus work was on Reddit. And I learned that from a patient.
Yeah, yeah. But I agree with you. I mean, in some respects, the patient comes in with some pretty good questions,
Mhm.
and you're not having to start from scratch sometimes, or really get down to really, I don't want to say basic, but the elementary part of your surgery. You can be a little bit more descriptive and be a little bit more, I don't know, at the next level of understanding, because they do have a little bit more understanding of how things are working now, because there is so much out there. You can chat GPT, what kind of meniscus surgery should I have if I have this finding? So there is a lot
Or
of
they
that.
put their MRI results into ChatGPT before they came in to see you. And
Oh,
they'll be like,
interesting.
well, I already know this about my MRI or something. Like they have an opinion coming in, and sometimes their opinions are correct, like 100% accurate.
Mhm.
And sometimes it's a little bit more of a discussion, but you get access to things a lot quicker now. And it's just
Yes,
an interesting, evolving part of what we're doing, I think.
yeah, I think so too. So who would be who are the typical patients that come in to see you?
I think people kind of fall into maybe two to three categories. I've got the athletes, right? Whether they're high school age, college, adult athletes, right? You can be an athlete at any
Sure.
age. And so that's one type of patient population where they're very much active in sports, something happens to them. They were at basketball that day, they fell, an injury occurred. That's kind of,
Mhm.
then you get into kind of just your more middle-aged group that are having degenerative type injuries occur, and not always with some big traumatic story, like they misstepped coming down with their laundry basket. Or I had someone the other day fall in the rain and they grab the handrail and the shoulder dislocates. So they've lived a very healthy life, no orthopedic problems, and then some moment happens, but now they're debilitated by it. And then you get into much more my older population, meaning 65, 70, 80 year olds who have arthritis and they do well with their arthritis, but they have pains. And so I try to help manage that pain. Or they've lost their ability to move their arms for certain reasons, whether that's arthritis, tears that have just happened with time. So I always see, okay, what's my patient like? What's their goal? What's their function? What do they want to be able to do? That's
Mhm.
realistic, right? Because some people
Right.
run a marathon all of a sudden, you're like, did you ever? And they're like, no. I'm like, maybe not today, right? So I think it's important to kind of gauge where your patients are at. And some people always wonder, like, do you only see athletes? No, probably see less athletes than I do see athletes. That's just kind of
Mhm.
this overarching title of what I have as a sports medicine specialist. But majority of my patients didn't get hurt playing a sport. They got hurt because they fell. They got hurt because they were in an accident. They got hurt because they have a repetitive job where their hands are over their head
Mhm.
all day long. So it's not you have to be an athlete to see me or be treated by someone like me in sports medicine. It's just kind of what they call what I do.
Got it. Okay. So let's talk about a little bit about we'll start with shoulders. What does a typical exam look like from when a patient comes in to see you? Do they always start with an X-ray? How do you determine if they need an MRI, or and what kind of exam are you doing if they come in to see you?
So if someone comes in with zero things, meaning zero x-rays, zero MRI, and I'm the first stop they're making on their journey,
Mhm.
my first visit is very much a history, right? I can
Okay.
pretty reliably predict an injury or what may be wrong based on the history the patient provides. And that goes back to medical school, right? History taking was
Hmm.
like medical school 101. But between
Yeah.
someone telling me how they got hurt, how long it's been hurt, what their main complaint is, what is it weakness? Is it pain? Is it stiffness? Did they fall? Did they play a sport? Like I can already in my mind visualize what's about to kind of unfold. So here's like number one. Physical exam, very important. Shoulder physical exam takes less than 5 minutes to complete. It's a very routine thing where I'm checking your range of motion, your rotator cuff strength, and then if I'm concerned about instability, I'm checking for labral pathology. And
Okay.
then there's a couple little extra tests, but that's very like quick. That's probably the shortest part of the visit. Based on those parts, I already should have an idea of what's wrong with you.
Okay. And just to back up for those that might not, because I understand all those terms, but the difference between what a rotator cuff injury is versus what a labrum injury is.
So, rotator cuff is four muscles around our shoulder, and it is what allows all of us to lift our arms up, kind of externally rotate, internally rotate, put our hands behind our back. Many people, whenever their shoulder hurts, they just automatically say, my
Yes.
rotator cuff. And they
Yes.
can be very young saying that to me in their 20s, for example. It is very rare for a 20-year-old to hurt their rotator cuff without a specific traumatic incident occurring. Rotator cuffs are much more for my 40 plus age group, but very much
Hmm.
so my 60 plus age group.
Yep.
I think the data shows that about 30% of patients over the age of 60 have a rotator cuff tear, and then that number jumps up to almost 60% when you're over 70. So, rotator cuffs is much more of an aging issue, and it can tear from a fall, a trauma. It can just tear with time. And that is what most people think is wrong with them is a rotator cuff tear. The labrum is not a tendon, it's not a muscle, it's this little tissue ring around the socket of our shoulder that creates stability, particularly when we're young. It is very important when we are under 30 years old, very
Yeah.
important when we're teenagers. And when somebody injures their shoulder at a younger age, it's typically the labrum that's hurt. And that
Okay.
comes with shoulder dislocations most often. And the labrum becomes less relevant as we age because it just isn't needed for that shoulder stability. The rotator cuff really is. So when I'm dealing with younger patients, usually under 30, I'm checking, did you dislocate your shoulder? because
Okay.
that's usually the biggest traumatic event, and that causes the labrum to tear. And when you're that age and that happens, a surgical discussion is pretty high on the to-do list because of that risk of recurrent shoulder dislocations if we leave that labrum torn.
Is
Versus
it still common that if you've had multiple dislocations under a certain age point, then you are more likely to dislocate further on and really becomes surgical?
right, right.
That's
And
still the case.
a lot of the data is showing that after your first dislocation, like as a teenager,
Mhm.
early 20-year-old, surgery should be the first step almost. It may not be immediate, like you can finish your season. There's a lot of
Mhm.
data showing, okay, finish your season if you're an athlete.
Okay.
During your off season, the risk is so high that you're going to dislocate the next season. You should be doing your operation, even
And
after one dislocation.
are there certain sports that you're seeing more of this in with youth athletes? I mean, are we talking water polo or are we even talking basketball or what 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 do you think?
You see football, obviously, from landing on an outstretched arm. Any sport where you can fall, right? Where your arm has the risk of like being what catches you when you fall. Wrestlers dislocate their shoulders. Gymnasts have their own
Mhm.
hyperlaxity issues. Swimmers, not so much. They are actually born oftentimes with something, not born, but they have something, a more multi-directional instability, which is very different than a shoulder dislocation. Lacrosse, any contact sport, shoulder dislocations are happening.
Anything where you can kind of get your
Get
arm.
that arm up. And in water polo, it's happening when you're trying to throw the ball and someone catches your arm and like pushes you back. That's how it's dislocating.
Okay.
So I contact sports are obviously the biggest thing, but you'll see it kind of across the board.
Okay. Got it. Okay. So now you've kind
Done
of
the history, you've done the
yeah.
exam, and
Hmm.
now we talk about imaging.
Okay.
That's a hot topic in the sense of x-rays, right? X-rays is
Right.
the most basic thing that we can get from a visual perspective, and x-rays show us bones. They do not show the rotator cuff. They show the labrum. And some people want to say, "Oh, I got told I have a rotator cuff tear on x-ray." No. No, that's not how it's diagnosed. I think x-rays are important in traumatic situations because I
Hmm.
want to make sure you didn't break a bone, right? You
Sure.
got to know if you broke a bone. That's where x-rays are very useful is in acute traumas. The next part where x-rays are important is if I suspect you have arthritis, because x-rays show arthritis very well. And do I suspect that in my 30-year-olds, 40-year-olds, 50-year-olds? Not really. But as people get older, arthritis is an important consideration with shoulders. And so an x-ray will help show that. Why so many people get x-rays? Unfortunately, insurance companies often require an x-ray to be documented and done before they will approve an MRI. So I very much rely heavily on MRIs for what I do, both in
Okay.
shoulders and in knees. But a lot of times I cannot get an insurance company to approve an MRI if I have not documented what their x-ray looks like. And it's not that they're doing wrong by asking that. They are doing it so that they don't use excessive MRIs. But when a young patient says to me, like, I know I didn't break my bone, and I agree, I know
Yeah.
they didn't, and they're like, why are you getting an x-ray? It's really sometimes a box I have to check in order to get
Mhm.
what I want, which is the MRI.
What about diagnostic ultrasounds? Have those been part of your practice in shoulder? I know you can do that for shoulders for rotator cuff.
Right.
I don't know what else you can look at in the knees, but where does that fall for you?
It is not a big part of my practice purely because I was not trained that way.
Got it.
There are many non-operative sports doctors. They often did something called a PMNR residency. So
Mhm.
they are a different subset of doctors. They cannot go to they're not surgeons, but they do.
Right.
And a lot of them have gotten that specialized training to use ultrasounds for that purpose. And there are surgeons that feel very comfortable with diagnostic ultrasound in the office. I use ultrasound for injection purposes and
Okay.
feel comfortable using it to guide some of my injections, but I personally don't have it as a big option. But there are several providers that do, and they'll use it actually after surgery too to check their work. So if someone has had a rotator cuff repair and they're maybe concerned that it retore or
Mhm.
they just want to see if it healed, they may have that skill set to do it in their office. It's just not a part of my clinical.
Got it. Okay. And is it mainly used for shoulder rotator cuff, or is it also used in the knee?
It's used in so many places that I wouldn't even expect, meaning elbow pathology, knee
Oh,
pathology, in
interesting.
the shoulder, ankle. And it really is the non-operative area of sports medicine that utilizes it so much more than I think
Sure.
surgeons.
Yeah, because it's easier to do. You can do it, like you said, you can do it in office. You don't have to send them out to an MRI
Rough
center.
it out. Correct, correct. And
Got
so
it.
you can look at the perineal tendons, you can look around the ankle. There are so many skills within that. And I've taken time to meet some of my colleagues in the area that has
Mhm.
that as a skill set. So that way I know I can't do it. I've got someone that
For example, if someone was, deathly afraid or claustrophobic with an MRI, maybe wasn't even willing to, take a Valium or whatever to get in the tube, perhaps that would be an
perhaps,
option for
and we
them.
still have the open MRI options, which
That's
I will
true.
say a lot of people get those. The downside to the open MRIs is sometimes the quality is not as good. And so
Mm.
you're not getting to see the same as you do on the closed machines, but at the same time, there's still an option. And many patients, like you said, that's a tight machine. They're
Hmm.
small. And whether you're small or not, it's a small machine. And
Yeah,
so I understand completely when patients will say to me, I can't handle it.
especially because shoulder is head first, right?
Head correct. Yeah. You're
Knees, it's easier. You can go
like
foot
this in
first.
there. It's a tight squeeze. It's a
Yeah,
tight squeeze.
yeah.
When it comes to the shoulder visit, sorry, knee visits, it's a very similar process that I go
Yeah.
through with the shoulders, meaning the history is huge. I can almost diagnose what's going to be wrong based on that history. The physical exam is very quick. It's a range of motion. So, how well does the knee move? I'm checking for points of tenderness, and then I'm checking the stability of the ligaments. And
Hmm.
between that history and physical exam, a lot of knee issues are diagnosed, but then we go to the imaging for confirmation. And
Got it.
again, that story with the x-rays, I find them very important, probably more so than shoulders, because people
Okay.
develop knee arthritis a lot earlier than shoulder arthritis, and it's much more common. So I will get surprised by some younger patients in their late 30s to 40s, and I get their x-rays and they're arthritic already.
Wow.
It's
Yeah,
important to talk about with patients.
sure.
And then the MRI still is my bread and butter useful source to then
Mhm.
find out what's the status of their meniscus, what do their ligaments look like, what's their cartilage look like, because you get that more fine detail on MRI.
Can you talk a little bit about the difference between doing an MRI with contrast versus just a plain MRI?
I rarely need to use one with contrast
Okay.
for two reasons. Number one, our machines have come a long way. So
Okay.
the quality of MRI machines are so good now that if you are in one of the better versions based on the Tesla system, that's how they're like measured, the quality of them, you really don't need that contrast in the knee. The use I use for contrast in the knee is if I have already operated on a patient's meniscus and I've repaired it and I'm concerned that they tore it again, they didn't heal. Contrast has been shown to kind of help our ability to interpret the MRI.
Okay.
But in general, with meniscus injuries and the use of contrast after operating, whether you use it or not, our ability to interpret MRIs is not great. So the best MRI I'm going to see is someone who's never had surgery on their knee because like it
Okay.
looks how it's you're getting a lot of information. Our ability to discern new tears from prior surgical post-operative changes to lack of healing is not great. And I have that conversation with all my patients going back for an MRI after I've operated on them. Because when you're making a decision about potentially operating on someone again, no longer is it only what the MRI shows. It's very much what's the MRI show, what's your physical exam, what are your complaints, and you have to put those things together to like actually predict more reliably what's going to be wrong.
Okay. Well, that's great for me to hear because I hate needles, and so contrast
Yeah.
is not.
And it's not comfortable. Patients don't
It
like
is.
no,
Yeah.
don't like it. And with shoulders, the use of contrast happens a little more frequently because of that labrum we talked about before. You really shouldn't need contrast to diagnose a rotator cuff tear. Again, the quality of the machines are too good to need that. That's something that we should be able to see without contrast. Because the labrum is not as robust of a structure in the shoulder and the tear can be much more subtle, that's when contrast gets added oftentimes. And I've had situations where I'll get a regular MRI on somebody that I suspect a labrum tear based on history and exam, and the MRI comes back normal. Like, no, I don't believe it. I don't believe it. Like, there's got to be something wrong. And then I'll send them back again and get it with the contrast, and there it is. Now you see the tear.
Got it.
And I'll have that conversation with patients ahead of time that says, like, hey, we can try without the contrast. But if it comes back normal and I'm still convinced you have a tear, you may be getting a second one unless you just right off the bat want to get the contrast. And then they're like, okay, and
Yeah.
we make that discussion and decision together.
Got it. So then when you're trying to, when you've figured out kind of what the issues are and you're trying to decide, is this a surgical situation? Is this a conservative management? What are some of the conservative management things that you offer? I know there's lots of different types of injections, for example. When are those appropriate, or when are those appropriate to try before even moving on to surgery?
So I think that everything's a conversation, right? And everyone, it's their choice as to what they want to do. I'm never here to demand someone to get an operation, but I think my job in the process is to help like give you the platter and then you choose
Yeah.
what you want. And so that starts with conservative treatment options. And there are many conditions in both the shoulder and the knee, the elbow, the hip, all over our body that don't require surgery. Is surgery an option? Yes, but is it necessary? Not always. And it's really important that I always want to understand my patient's goals and
Mhm.
expectations because that very much sometimes guides you which way you need to go. But you can do well without operations. And part of that is, quite frankly, involvement in physical therapy is a huge part of what we do, right? So, conservative treatment, meaning you modify some of your activities, take away what's causing the pain, whether that was an overhead sport and you need to back off that for a while, whether that was weight training, whether that's some work modifications. Just starting with basic oral anti-inflammatories. So many patients say, I don't want to take medicine, and I'm probably
Yeah,
just as guilty as them. But there are some uses of using anti-inflammatories,
sure.
right? If you're having an inflammatory condition in your body, well, maybe target it with some ibuprofen, some Motrin. Then talking about physical therapy, again, huge part of it. Go to physical therapy for basically everything. It can help. And then injections. So injections from the most basic level can be things like steroids or cortisone, as people know that. I use them often in knees as my first line of defense when someone comes in with pain that is not a trauma related pain, but when we're
Mhm.
talking more the degenerative conditions, arthritis, potential meniscus injuries in older patients, steroids can be very helpful. And some patients respond beautifully to them. They get a steroid injection, they think it's the best thing that ever happened to them.
Yeah,
Like that
yeah.
can be months of pain relief, and that's great. It's low cost, it's easy to do in the clinic. You're in and out in minutes. Like it's not hard to do. What I get frustrated sometimes with steroids is the unpredictable nature of it. I've had so many patients say it was so great, I loved it. And then you have somebody with, you're like, this will be a slam dunk, it's going to work. And they're like, it didn't help me at all. And like, and then the person that has horrendous arthritis or something so wrong, they're like, this, we are wasting your time. And they get the shot and they're like, oh my gosh, like thank you so much. So it is wild to me just how like variable that steroid response between every patient I have is. But I think it's a great option for a lot of things.
Okay.
And shoulders as well. Steroids is kind of the workhorse in shoulders. Hyaluronic acid injections. People sometimes say, I want the rooster shot. Gel injections is how they call
Yeah.
it. And that acts differently in the knee than a steroid. It's more of like a lubricant. Again, I have patients that love it and like, oh, give it to me again. And then I have patients that go, thank you, like you did no good for me. I don't find it harmful, but I never promise somebody like this is going to be like the slam dunk game changer because I don't think that applies to all patients. It is FDA approved to use in knees. It is not FDA approved to use in shoulders. That's an off-label use in shoulders. And so
Okay.
when people ask me for it in shoulders, I have to say like, hey, we can do it, but they're usually having to pay cash for it. I do not know how to make that be quiet for you.
I don't hear
You
anything.
hear that when it goes
Good.
off? Okay, good. All right. Someone's texting. I'm like, I don't know how to turn that off. So it's not FDA approved in other body parts. But again, do I find it harmful? No. Do I think it's going to help? I don't know. And then PRP, that's platelet rich plasma. That's when we take someone's blood in a blood draw in the office, we put it in a machine, and then we separate out some of the cells in it and re inject it into a patient. Kind of more of a hot topic. Is it going to help? Is it not? Again, no guarantee. Is it
Right.
expensive? Yes. If you're trying to avoid going into an operating room and you want everything thrown at you, go ahead, get the PRP. Like,
Yeah. Yeah.
give it a try. It's mostly been shown most effective in early stages of arthritis in the knee. And that's when I'll push it more on my patients. If they're like, I don't want surgery, give me what I can, I'll pay anything. Okay, try PRP. But even in the shoulder, not going to heal your rotator cuff tear all of a sudden. It might help some pain, but it's not
Sure.
going to
Yeah.
like regenerate the torn tendon back together again.
Right.
So I
Right.
think it's really important that the patients have options, but also get realistic expectations and not false promises of like, this is the magic juice that's going to make it better. Because I don't think we're there yet. Well, hopefully one day, but not yet.
Yeah. What would you say are kind of the most fun shoulder surgeries for you to do?
I love a rotator cuff surgery. Those are
Okay.
fun because you're almost like putting like a little puzzle back together. You know there's a tear, but sometimes not until you're in the shoulder, you know which direction the tissue moves and does it come back together? Do you have to go side to side? Do you have to bring it down this way? There's just various things and you get surprised. Then I mean, no one loves surprises, but you have to like be able to think on your feet and sometimes outside the box of how you can fix something. So I love that operation. I will say that's one of the most challenging group of patients, though, because they don't like you afterwards for a few months because it
Yes.
is uncomfortable and you're
Yeah.
asking a lot of them. You're asking them to be in a sling for about 6 weeks. You took away an extremity from them and
Hmm.
oftentimes their dominant hand. And so I think that's a huge part leading into surgery that I talk to my patients about so they can mentally prepare like I'm shutting you down for a
Right.
long time because
Right.
it affects their healing, meaning their mentality, how they feel about it. And we talk so much about how therapy is going to be a huge part of their recovery to really set the stage to hopefully mitigate some of that. But my rotator cuff patients don't love you for a good
Yeah.
3 months. And then they're like, oh, thank you. Like, thank you so
Yeah.
much.
Yeah. Yeah. How about the knees? What's your favorite knee surgery?
I love a meniscus and an ACL. I think from an ACL perspective, those are athletes most of the time, right? And so these are people that they got hurt doing something they usually enjoy. They want to get back to it. They're a motivated group of patients to get better, but another 9 month to a year long recovery at minimum, right?
Yeah.
And that's a huge conversation topic. But I always joke that's a surgery where you never have a moment to like breathe. Like every step of that surgery, you're like, okay, get this right, do this right. And so it's just a constant shuffle of moving instruments and getting things right where you want it. And then meniscus surgeries, I've really tried to target meniscus repairs. It's been a huge part of my practice. I think that is a big difference you'll see in younger surgeons versus maybe some that are more senior, that we got the privilege of training when there were more toys that existed. So
Yeah.
more instruments that allowed us to repair meniscus tears that were previously just trimmed out or removed. But now we have so many little tools and tips and tricks that we can really try and repair a lot of these meniscus tears as our patients age that were just used to be cut out, right?
Yeah.
And predispose
Yep.
someone to terrible arthritis. So I always tell my meniscus patients, because a lot of people get other opinions, right? And they
Hmm.
should. And I say, I don't treat your knee based on your age on the paper. Like I treat your knee as the age it is that I'm staring at in your knee. So if I'm inside your knee and you look like you have a 20-year-old's knee, but yet you're 65 and you're on board for the recovery of a repair, I'll repair
Hmm.
meniscus. I'm not just going to take it out because your age says that's probably what should be done. But again, those are conversations in the office. Those are not things that I just like fly by the seat of my pants and go like, okay, this is what I'm going to do. I really want to know what are my patients' goals? Can they participate in the recovery? Like
Right.
what
Right.
what's realistic or not? Like, do they have a job that they get 1 week off and they can't be on crutches for 6 weeks? Well, that's important to know. And
Sure.
if you're not asking those questions beforehand, I think you're really doing a disservice to your patients because you're not really listening to like what they need for their life because it may not be what the guy next door needed, right? Or your sister, your brother. You really need to like listen to your patients of like what's going to make them better for what they need to do.
I like that. Is there anything I haven't asked you that you would like to talk about, or have
I
I
just
covered
think
it
that
all?
this is great, an opportunity. I appreciate it. So never be afraid to come see a surgeon. That doesn't mean we're going to operate on you.
Right.
I
Good
think a
point.
lot of people get nervous when they see the word surgeon when they're going to a doctor that all we care about is operating. Don't get me wrong, I love to operate, but I spend more of my day walking patients through conservative treatment options and when needed, surgery, right? But never be afraid to like come and see someone, get a diagnosis, because that doesn't mean anyone should ever force you into someone's operating room. Like we're just here, or at least I'm here to help facilitate. That's how I like to look at it.
I love that. I love that. So, Dr. Didinger, where can patients find you? Because you're with Advanced Orthopedic Care now. Is that what it's Advanced Orthopedic
Yep,
Care? Yeah.
advanced orthopedic care. So I see patients in Marina Del Rey. I see
Okay.
patients in Los Alamitos. Newport Beach, and San Pedro. So you can kind of find me all over town, which is nice that I kind of can touch in different areas. One phone number to call to schedule all that. And you would think I would know that number. I'm not that smart. Hopefully, we can
I'll
put
list it
that
below.
along
Yep.
there. We'll be able to link it. And then we have a website that's my own personal website that's just finishing its development literally this week. And then the group's website, I have a spine partner, Dr. Kush Verma, talking about how your paths cross in life. I met him when I was a medical student in a whole nother state, in a whole part of the country that we don't live in. And
Wow.
so it's cool that someone that I did research for 14, 15 years ago is now my partner. And so it's a great balance of we cover most of our body parts between him and I. And then
Great.
we also have a pain management doctor, Dr. Halal, that works with us. So we try to help everybody the best we can between the three of us. And just reach out if you need anything.
Thank you so much. I really appreciate you coming on the podcast, and hopefully we can have you back again and get a little more in depth into other areas. But thank you so much for your
Thank
time.
you for having me. I appreciate it.
All right, we are done with the recording.
Thank you.
Thank you so much. I
Absolutely.
will get this kind of all, I put it into AI software that
As
kind
you
of
said,
flips it
yeah.
for me, but
AI does it all.
does it all. But I will, connect you with everything that you might need, and then I'll let you know when we're gonna post the whole video and the little pieces. And I really appreciate your time.
Yeah,
Thank
I
you so
agree. That was
much.
cool. I like that. It was funny. A doctor did a podcast with Dr. Verma the other day, and they're like, "Oh,
Uh-huh.
they want to bring me on." And I went to talk to him, and it was funny. He's like, "Oh, unless you're affiliated with my surgery center, I won't have you on my podcast." I was like, "Oh."
Oh,
Oh, I was
okay.
like, okay.
Wow.
Dr. Verma does operate at his surgery center, so I understood that. But it was just funny that he's like, I know you just joined him. Like, I want to have you on. You do sports, blah, blah, blah. But he's like, but not until you're affiliated. And I was
Interesting.
like, I'll get on that. Not
Interesting.
yet. Like, it was just
Yeah,
that was like the take on it.
that's so interesting. Well, hopefully maybe I'll have Verma, is that his
Yeah,
last
Dr.
name?
Verma. Yeah. And I'm going to
Dr.
bring him
Verma.
by so he can introduce himself to you
Oh, that'd
guys.
be great. Because
Literally works out at the gym at Allegiant, right
oh
up.
yeah, I know Allegiant. Yeah,
Yeah.
yeah. They're
That's his
great
gym of
partners with
choice.
us. Yeah,
Yeah.
they're great
That's where he
partners with
works
us.
out every day.
And honestly, there's not a lot of great back surgeons
Right.
around. I mean, we've had a few more come in over the last 10 years or so, but prior
It's
to
hard because
that,
so many of them start with one set of intentions, and I feel like that gets jaded through
yeah,
people's careers. Like
yeah,
not motives, but like they want to help people, but it's spine surgery in particular because there is so much money involved in it, complexities.
yes,
That it's interesting because I hear so many stories like, oh, I went to so and so, but then I went to so and so, and I'm like, how many people you go? Like, where are you all
yeah.
going? You're all over the place. Yeah.
Well,
Yeah.
definitely bring them in. We'd love to meet them.
For sure. And
All right.
I'll be crutching myself on over
I
and
know. Let me know when you want to hop on Alter G when you get cleared for
I can't
that.
even believe that this is like I'm like I was looking at running shoes today. I was like, what am I looking at running shoes for?
Why? Yeah.
So then I was like, I should get some weightlifting shoes. I was
There you
like,
go.
that's all I'll be doing. All right, we'll talk soon,
All
okay?
right.
Thank you so
Thank
much.
you.
I appreciate it.
Bye.